Good evening. As mentioned, I'll be presenting on loss to follow-up among women in Option B Plus program in Lilongwe, Malawi. In this presentation, we'll mainly look at understanding outcomes and reasons for loss to follow-up. First, let's look at a quick background to Option B Plus PMTCT strategy in Malawi. The use of antiretroviral therapy in HIV-infected women significantly reduces vesicle transmission. Some studies have shown reduction from 25% to 2%. In 2011, Malawi Ministry of Health embarked on a novel PMTCT program known as Option B Plus. In this program, lifelong ART is provided to HIV-infected, pregnant and breastfeeding women, regardless of their WHO clinical stage and or CD4 count. And there's also provision of nevirapine syrup to infants for a period of 6 weeks since birth. Implementation of Option B Plus resulted in a 7-fold increase in the number of women starting ART for PMTCT between Q2 2011 and Q3 2012. Although there have been such a success in the implementation of Option B Plus, the program still faces some challenges, such as loss to follow-up from care, which is a considerable barrier to the effectiveness of PMTCT. 27% of women who start ART based on Option B Plus are lost to follow-up at 12 months in the national program. This is according to Malawi HIV report for December 2013. And again, through other studies, we have found that 24% of these women are lost to follow-up in the first 6 months. This is quite common in facilities with high patient volume. There was a study by Lyson Tentani published in the AIDS journal. Though we know that this is a challenge in Option B Plus, there is limited information about loss to follow-up in Option B Plus. So we therefore conducted a study where we looked at 3 main objectives. The first one, we had to determine factors associated with loss to follow-up among women starting lifelong ART for PMTCT. Second, we aimed at determining the true outcomes of women who are lost to follow-up from PMTCT program. When they're lost, what exactly are their outcomes? And lastly, we attempted to describe the reasons for loss to follow-up for these women who are lost from the PMTCT program. How did we do this study? I'll share with you first the study design and study setting. We conducted a retrospective cohort study using routine data from a real-time touchscreen-based electronic medical record system. With this system, information is captured in front of a patient, so the system also helps health providers, guiding them to the questions that they need to ask the patient on their clinic review. We also collected information from our area active patient tracing program. This again is a routine program. The study was conducted at Bwaira Hospital in Lilongwe, Malawi. Bwaira Hospital is the busiest hospital in the country with the busiest ANC and maternity wings, with over 14,000 ANC registrations a year. And Bwaira Hospital provides PMTCT services in collaborative effort led by the Lilongwe District Healthy Office and other partners. Every month, the clinic registers around 110 women on ART based on Option B Plus. But what are the services that Bwaira Hospital provides under PMTCT? All pregnant women with a non-HIV status undergo a group HIV counseling session. From there, they go through opt-out provider-initiated HIV testing and counseling. Those that are found to be HIV positive, they are referred to expert mothers who provide psychosocial support and adherence support at the initial visit and even on some of the follow-up visits. All women who are identified as HIV positive are registered in the electronic data system and are started on lifelong ART, a majority of them on the same day of HIV diagnosis. And ART pickup visits are scheduled monthly, and at each visit, the number of ARV pills and the new supply of ARVs are recorded in the electronic system, and the system automatically calculates the next appointment date. So how does our tracing program go? It has to be noted from the start that the tracing program's aim is to decrease treatment interruptions and prevent loss to follow-up. So a list is generated of women who are lost to follow-up, who have missed an appointment by at least 3 weeks. And this list is confirmed by checking in the paper files, because it's generated in the electronic system, so they have to confirm it in the paper patient files. And those women where we have confirmed that they are lost to follow-up, they are traced if they consented at ART registration, and attempts are done up to a maximum of 3 times by phone or home visit. And the tracing team uses a standard questionnaire, a paper questionnaire, where they document tracing efforts, tracing outcomes, and reasons for missing an appointment. In terms of analysis, our tracing outcomes are categorized as follows. We have dead, uninterrupted treatment therapy. This is where we interview a woman and tells us that they are still taking ARVs. Maybe they collected ARVs from other sources. And another one is treatment interruptions, where we interview a woman and she says, I'm currently taking, but I missed some dose maybe 10 days ago. And we have safe transfer out, where a woman goes to another clinic without telling the providers that they have transferred out. We have stopped ART and never started, where a woman collected ARVs and they went home, but they didn't start taking the ARVs. And the last group is not traced. It has to be noted that for the purpose of the tracing program, the loss to follow-up was defined as missing a scheduled clinic appointment for at least 3 weeks. We use multivariate Poisson regression to investigate the factors that are associated with loss to follow-up. Here are some of the findings on patient details and loss to follow-up. Between September 2011 and September 2013, we had 2,930 women who registered for ART for PMTCT Option B+. 84% were pregnant and 14% were breastfeeding. The median age for ART initiation was 26%, and median follow-up was 8.2 months. Out of the 2,930 women who started ART, we had 577, that's 20%, who missed a scheduled clinic appointment for at least 3 weeks. And I want just to draw your attention to the 272 who collected ARVs only once and they didn't return to the clinic. The overall instance of loss to follow-up, according to our definition of loss to follow-up, was 23.5% per year. In terms of retention, we got the following numbers: 85% at 3 months, 82% at 6 months, 79% at 12 months. You see there's a sudden drop at 3 months there, just looking at the numbers. So we further looked at the factors associated with loss to follow-up. I've just presented the adjacent late ratios, and I'll take you through the factors that were associated with loss to follow-up. The first one, you see that women who were aged between 13 and 24 were at higher risk of loss to follow-up. And again, women who were breastfeeding were at lower risk of loss to follow-up compared to those who were pregnant. We also found that those women who started ART the year when Option B+ was established, they were again at higher risk of loss to follow-up. So we further looked at the outcomes. After tracing them, we further looked at the outcomes of those that were lost to follow-up. We had, as I earlier mentioned, 577 women who were lost to follow-up. 40% were successfully traced, and 60% could not be traced. We compared the two groups, looking at their age, looking at the year of ART initiation. We also looked at whether they were breastfeeding or they were pregnant. We found that the two groups were not significantly different. When we further looked at those that were successfully traced, the following were their outcomes. 4% had died, 30% had transferred to other clinic without informing their previous clinic. And 66% were still alive. We further explored on what happened to the 66%. I want to draw your attention to the biggest group, which is stopped ART. Out of those that were alive, 77% had stopped ART. And that's the group that we'll talk again further. And we had 6% that had treatment interruptions, and 9% were on ART with an interrupted treatment therapy. And 5% had not started. 3% refused to be interviewed. So we went further to look at why did 77% stop taking antiretroviral therapy. Out of the 118 who stopped taking antiretroviral therapy, we managed to get information from 111. So some of the women could provide 2 or 3 reasons in this case. I've presented the reasons according to their frequencies. Majority of the women, they said they couldn't come to the clinic to collect ARVs because they traveled away. So they got to their village to see relatives, or they had to do some other things in other places. About 16% they reported of transport problems, and some reported of limited information about ARVs, that they didn't know that they have to take ARVs for life. They thought maybe after the first bottle, that's where they have to stop at. And some indicated suspected side effects. They felt they were unwell, and they thought that the cause of that problem could be the ARVs. Some were too weak to come to the clinic or too sick. And we had information for that in around 10% of our group. What do we get from these findings? You'll see that there's overall loss to follow-up of about 23.5% per year. When we compared this to the general HIV-infected individuals accessing ART for their health, we found that it was 9.3% per year. This one is a bit high. It's higher than what we find in the general population. We also found that 47% of women who were lost to follow-up received ARVs once and never returned for their appointment. It may suggest that there is a certain proportion of these women that never start ART, even if they collect the ARVs. We also found that being older, that's 25 years and above, was associated with reduced risk of loss to follow-up, possibly because they have a settled lifestyle which allows them to better manage ARVs for PMTCT. Such observation of higher age has also been observed in the general HIV cohort. There was also a study in South Africa where they observed a similar thing, that younger women are easily lost to follow-up in these PMTCT programs. We also noted that there's a likelihood of loss to follow-up decreasing with increasing year of implementation, which I think can be attributed to the stabilization of the PMTCT program. There was also a sizable proportion of women that could not be traced due to incorrect addresses documented in the patient files. We thought maybe women would have given false physical addresses because of fear and stigma. But this area needs further investigation because we compared the two groups, those that were successfully traced and not successfully traced. We didn't find any significant differences. We also found among those that were lost to follow-up and traced, half had stopped ART, leaving their infants at high risk of HIV infection. And a third were transferred to other clinics, which suggests that our national estimate of retention may be underestimating the true values. What then do we recommend from these findings? We recommend that ANC and ART clinics should further enhance post-test counseling by engaging HIV testing counselors and expert mothers for in-depth ongoing counseling and psychosocial support, which has to be more systematic than maybe what we are currently doing. We also recommend establishing targeted programs for youth that have to be youth-friendly in ANC and ART clinics. And we recommend ART clinics to establish data leakages through which information of patients that transfer out can be shared. If the clinics are using electronic data system, that should be easier for them to communicate and provide feedback on women that transfer out without communicating to their previous clinic. Lastly, we recommend further decentralization of PMTCT services. But if these women are going to secondary clinics, it means there's something else that is making them to go to that clinic. Usually there are better ANC and maternity services. So if we're decentralizing the PMTCT services, we need again to look into account that there is also good ANC and maternity services at primary health centers. Lastly, I want to acknowledge the foreign partners. Thank you.
Did you look at CD4 count of women who started Option B plus, please?
No, we didn't look at CD4 count on the women who started on Option B plus in this study. Mainly, when they are pregnant, they are just initiated on antiretroviral therapy without looking at CD4 count. Thank you.
Someone on 4.
Microphone 4.
Thank you for a really excellent and very interesting presentation. One question I had was that you asked the women for their reasons, the reasons they gave for why they were lost to follow up, why they couldn't take their ART. The reasons that we give are not always the reasons that we know, and sometimes the reasons that we give are the reasons that we feel are more socially acceptable. Did you have any sense, or did your staff have any sense that there were other reasons, other unsaid reasons that we should be investigating?
Yes, we feel that because of the way that these studies are done, the woman may give the information that they feel is desirable to us. And there was a study that is also being done by our colleagues, UNC, University of North Carolina, in the same area to get into the details of what exactly happens to these women.
Okay, we'll take one final question, microphone 2.
Thank you, David Lai from Save the Children. Did you have a chance to do virological testings on the infants as well, and whether these women who are lost to follow-up has any effects on their infants being born positive with HIV?
No, we didn't do that. Yeah.
All right, thank you.
No, that's okay.
So 2 brief questions. What was your loss to follow-up rate in 2013? You said it got better over time. Do you know what it was?
I think it was 9 point, in 2013, I think it was 9 point something per year. 2012, if I remember properly, it was around 11. Yeah, and it was highest in 2011. I think I don't remember the number for 2011, I'm sorry.
Okay,
Yeah.
and did you have any loss to follow-up information under Option A prior to introduction of Option B plus?
No, we don't have that information.
Didn't track women?
No.
Okay, thank you very much.
Thank you.